will, because we have very experienced presenters with us today. So I'm excited. The idea for today was that we gather because we have three newly funded or refunded quality enhancement research initiatives funded through the VA that are in the region. And we are working actually closely with each other. We are developing collaborations. And so this is a great opportunity for you all to learn about these three queries, what the queries are, and then specifically these three queries, what we are doing. And then also think about the specific unique features that queries allow for in terms of implementation science research, which all of us are very interested in engaging with. So I am going to now share my slide, if that's okay. And I might have to switch with you. And we'll be introducing us and then kind of helping us get through the presentations, but I will be handing it off also to my wonderful colleagues who are here to represent these three queries. And I'm going to keep it in this format. I just wanted to check if everyone can see the slides okay. Wonderful. So as I mentioned, we are going to present about these three queries who are independent entities within the VA, but we are also collaborating with each other. We have some overlapping personnel and definitely collaborations outside of the query. So it's really a fortunate opportunity for us to present together. You will hear about the Empower 3.0, the CARE-VASH, and then the iTRIP queries. And I will let the presenters actually introduce the full title and then also the specific principal investigators who are involved in each query, but you can see those on the slide. Before we present, I wanted to show you what our plans were. We are going to have just a very brief introduction to the query. Perhaps I am the least qualified to do that, and I will do it today. Because of that, it's going to be brief. But then there will be opportunities to ask questions from those who have been with the VA for many, many years, very much integrated. And then we will have each query do a mini presentation. It's going to be just like a 10-minute quick overview of what each query is really focused on. And then we will do a snapshot that brings the three together. We'll show you how we are similar and different. And then we'll open it up for discussion. As you can see, we are planning for plenty of about 20 minutes of discussion, and I'm hopeful that that will be there. And so prepare your questions, put them in the chat if you think you will forget them. We will collect them at the end. So in terms of the query program, as I mentioned earlier, it's the Quality Enhancement Research Initiative. It's within the VA. And if you could all just by a quick raise of hand, whether you use the Zoom function or your actual hands, show me if you are familiar with the query or heard about the query. If you could show me whether that's true. I'm looking for hands. Not too many I see. Perhaps it's still hard to get to this. Yeah, we have a few people who are raising their hands, indicating that they are familiar, others perhaps not. So within the query program, it was first started in 1998, and the goal was to bridge the gap between what is happening in research and clinical practice, which is basically the trademark or most important underlying reason why we do implementation science. However, the query is really pragmatic and it doesn't see itself as a research entity. So it's very important to think about it, that it's not a research program. It is about improving care and focusing on specifically improving care through evidence-based findings that are being now integrated in a more systematic way to improve outcomes for veterans. And it is often very methods focused in terms of the queries. They each have overarching cross-cutting methods and frameworks that they use, but then they focus on different types of programs. And you will see that each of our queries are focused on a different type of outcome series, but we are unified by the type of framework and methodology we use across these programs. Researchers partner with VA operational leaders as part of the query, and they use these implementation science frameworks, which many of you are familiar with, whether it's, CIFR, REAM, PRISM, other frameworks that you will hear about today. And they will embed this learning infrastructure, learning health system infrastructure within the VA to actually experiment and bring specific programs to the veterans and study those, collecting data. unique to these that very often, and I will hear from the other two queries, but in our case, that's true. The data is not directly collected from the veterans who are benefiting, but instead there are databases that are already collecting data, and it's based on that. And then it focuses on very important VA priority outcomes and indicators. And you will hear from each query which one they are focusing on. And again, there is a strategic methodology where implementation and sustainment is critical. So there is a focus on the continuum of, bringing the program. There is a pre-implementation work that happens that needs to be there for success. And then you move on to implement, but you also think about sustainment. What happens after the program is initially implemented? There is a rigorous evaluation, which is happening in partnership with the operational partners and also national partners. And then it promotes the application of these evidence-based methods using quality improvement science and real-world practice. In terms of where you can find query programs, there are many of them. The query actual programs are marked here. In addition to those, there are also partnered evaluation initiatives. There are evidence-based policy evaluation centers, implementation training resource centers, and learning communities. So all of those are indicated here in one way or another. As you can see, we have the two in the Los Angeles area that is here today. So we have Empower and CARE-VASH somewhere. Sorry, I'm missing that. But then we have the San Diego area, and we have the current query that James and I are co-leading. So these are the queries. You can find this actually online, and we can also share the slides. So with that, I'm going to invite Dr. Alison Hamilton, who is representing the Empower 3.0 query today, to present about their query.
Thank you so much, Borsika, and thanks everyone for being here today. I am Alison Hamilton, and I'm based at the VA Greater Los Angeles and UCLA. I'm an anthropologist by training, an implementation scientist, and have had the good fortune of being funded by Query for a long time. So in addition to leading Empower with the amazing folks you see listed here, I lead two of the training hubs and co-lead the Women Veteran Learning Community, which is a newer query mechanism focused on learning health system initiatives. I think just as an aside, before I talk about Empower, for folks who don't know about Query, Query was really at the forefront of implementation science in its earliest development, and I believe was really the first to put forth implementation science training under the leadership of Brian Pittman many years ago. The Enhancing Implementation Science series that we were doing a couple decades ago. So it really has had a lot to do with shaping the field. And, we're really lucky in VA to have these mechanisms to do implementation work that is entirely embedded within an integrated healthcare system. So it's we get to learn so much all the time and work really closely across the healthcare system. So I'm happy to share a little bit with you today about the Empower query. Empower stands for Enhancing Mental and Physical Health of Women Through Engagement and Retention. We are on our third cycle of funding. That's why it's 3.0. We're the only program of this kind to focus entirely on women, veterans, health, and healthcare, and work closely with several partners, mainly VA Office of Women's Health and the Office of Mental Health, but we have 5 other national operations partners as well who have been with us for what is now over a 10-year journey. So our current initiative, which is in its first year of the 3.0 cycle, is really focused on women, veterans in midlife. And what we're doing in this program is focusing on access to care and quality and experience of care by offering trauma-informed interventions that are, of course, evidence-based and that are aligned with women veterans' high priority health needs. And we're getting a little bit more into issues that we know are important and affect engagement in healthcare services, such as trust and well-being. And I'll share a little bit more with you about that on the next slide. But just wanted to mention here in terms of the co-leadership, there's a really significant emphasis in these queries on team science and on clinicians and non-clinicians partnering to do the work. I couldn't do this work without the folks that you see here and many, many others. But just to give you a sense, Dr. B. Mayberry is a women's health primary care physician, as well as being a health services researcher. Melissa Farmer is a medical sociologist, and our stats and quantitative guru, and Erin Finley is a medical anthropologist like myself and also an implementation scientist. And it's a very multidisciplinary group that we have and very, very oriented toward team science. Next slide. So just by way of background, in case some of you aren't familiar with women veterans in particular, women are the fastest growing segment of VA users, and almost half of those who use the VA are in midlife. And we know in midlife, the risk of chronic disease increases, menopause typically occurs, and there are several health issues that could be prevented or at least mitigated if addressed, at this point in the life cycle. As I mentioned, we're interested in empower in trust as an issue that does affect engagement and retention in evidence-based practices and in healthcare overall, with some reports indicating that women don't necessarily have as much trust as we would hope in their VA providers, with only about 40% reporting complete trust in their providers. We know that when patients do trust their providers, it's associated with not only communication, but also care that is appropriate to particular populations' needs, as well as being trauma sensitive. And we know that when trust is not as experienced, it may affect healthcare utilization, including potentially departure from the healthcare system as a whole. And we have a series of studies that we're doing now on attrition from VA or departure from VA and what could help to retain women and veterans more broadly in the VA system. Next slide. So, super quick background. The first cycle of Empower was focused on cardiovascular risk reduction, anxiety and depression, and prediabetes. And we learned a lot and took those learnings into Empower 2.0, which we just completed back in the fall. We learned that it would be important to deliver our interventions virtually to increase engagement and also to focus on prevention. So we again focused on cardiovascular risk, prediabetes, and anxiety and depression, but in particular perinatal depression with 3 evidence-based practices. And we conducted a cluster randomized trial, hybrid type 3 project, where we trained folks in our evidence-based practices, and half of the sites were randomized to evidence-based quality improvement as a strategy, and the other half were randomized to replicating effective programs, both of these strategies being evidence-based strategies. So we're really interested, not really in which strategy was superior, but in which strategy was the best fit given contextual factors. We had a lot of success across the 3 evidence-based practices. So far, our data saying that actually the strategies were pretty similar in their outcomes. More to come on that. But what was really interesting and fascinating for us is that ROSE, the perinatal depression intervention, spread organically across the country with very little effort on our part. So not only did we train many hundreds within Empower sites, but actually well beyond Empower sites to the point where now it's being used in approximately 60 sites where we did not plan for it to be used. And Much of that is thanks to Ariel Lang, who's based at the VA San Diego, who provided all this training to hundreds and hundreds of VA employees. So she definitely deserves a shout out for everything she's done for Rose and Empower. Next slide. So in 3.0, we are implementing 3 practices: trauma-informed care, brief cognitive behavioral therapy, or whole health for symptoms of menopause, and women's move. Move is an intervention in the VA that is available to veterans, and we're basically doing a tailored version of move, and has many principles of evidence-based practices for weight management and wellness. Next slide. I want to make sure I don't go over time. So one of our questions is about the supports that sites may need to achieve successful implementation and sustainment of practices. So we're doing another cluster randomized hybrid type 3 trial in 18 sites across 4 VISNs, but there may no longer be VISNs, so we'll see what happens there. But we proposed it to be done across 4 new VISNs that we did not work in 2.0. Next slide. And in this case, we're using evidence-based quality improvement as our core implementation strategy because the Office of Women's Health, given success with this strategy over multiple initiatives, decided to roll it out across the country in their own initiative called Achieve. And so they said, why don't you go back to the Achieve sites, re-up their EBQI knowledge and use that as your strategy, which is great to build on their substantial investment. So we're comparing a booster in EBQI to a booster plus external facilitation, all at sites that have participated in this Office of Women's Health initiative. Next slide. So just in terms of next steps, we're currently in year 1 of 3.0, and we're in a co-production phase, which actually does involve interviews with women veterans themselves, to your point earlier, Borsika, as well as many other stakeholders who have particular expertise in our evidence-based practices. And then we'll move forward in the fall to randomizing sites and getting going with the trial with a host of evaluation outcomes in store. And I think that's it for me. Thank you so much.
Thank you so much, Alison. I really appreciate it. And what an incredible decade of work that you continue to build on. I have already learned some ideas that we should consider for our query. So I will hand it over now to the second query presenter group. Sonia and Emily are here, and I will let them take over and present on their CARE-VASH query.
Thank you so much. Thanks so much for having us, and it's a pleasure to be here. I'm Sonia Gabrielian. I'm a psychiatrist based in Los Angeles, here with Emily Treichler, who's one of the co-PIs on CARE-VASH, and we'll be sharing a little bit about our query. Our query is a new project that started in October, but I'll tell you a little bit about some other query efforts that that led to this. So I'll present the first half. Emily will take over midway, but I'll start by sharing our big picture impact goal. CARE-VASH query, which stands for Coordinated Access for Addiction, Recovery, and Equity in VA Supportive Housing, aims to optimize equity and access to evidence-based substance use disorder services among veterans in VA's permanent supportive housing program. So these are veterans who have been homeless but are in one of VA's largest homeless services, which allows veterans to live independently in permanent housing with financial subsidies and case management support. Next slide. So just by way of background, stable housing has increasingly been recognized as a critical determinant of health, particularly in VA, where ending veteran homelessness has really been prioritized. We know that as compared to housed veterans, veterans who have experienced homelessness have higher rates of mental illness and substance use disorders, and that broadly, these behavioral health disorders impair veterans' ability to both attain and retain housing, even when presented with really robust services like we have in VA. Next slide. HUD-VASH, which is the setting of our implementation project, is really sort of the center of VA's strategic plan to end veteran homelessness. I mentioned that it's a permanent supportive housing program. The VA really boasts that over the past 10 years, despite what we've seen locally, especially here in Southern California, an increase in homelessness, especially unsheltered homelessness here in Los Angeles and Southern California more broadly. HUD-VASH has contributed a lot to a 50% reduction in veteran homelessness. But what we often forget is we're really successful in this program in getting folks housed, but within the first 2 years, up to 40% of veterans exit that program, often for negative reasons. And substance use disorders are a really common primary or contributing factor. Next slide. Okay, so we have had a sort of distinct query program that we call LEARN. It's essentially a rapid program evaluation center. And that center, we had the opportunity to do an evaluation of the HUD-VASH program for veterans with substance use disorders that really provided preliminary data for this project. So we looked at a very large cohort of about 64,000 veterans who attained housing over a 4 fiscal year period. And we found that 66% of those folks had substance use disorders, and that folks with substance use disorders had 1.5 times the odds of a negative exit from HUD-VASH within their first year of move-in. So really supporting what we know in the literature about the relationship between substance use disorders and housing outcomes. Next slide. And we also know that substance use disorders are associated with service use. So when we adjusted for demographics and comorbidity, we could see that folks in HUD-VASH with substance use disorders use the emergency department with an adjusted odds ratio of 1.5. Similar use of primary care, but about 1.7 times the odds of using outpatient mental health, and really strikingly 10 times the odds of having an inpatient psychiatric admission in the year after move-in, which is clinically not surprising, but sort of the magnitude of the number is significant. Next slide. And in VA, we also have the benefit of not only having these robust housing services, but also really widespread implementation and dissemination of evidence-based substance use disorder practices. We wanted to think about both psychosocial practices and pharmacologic practices. So in the psychosocial domain, cognitive behavioral therapy for substance use disorders has been widely disseminated within VA, but less than 5% of veterans with amphetamine use disorder, which is highly prevalent, especially in Southern California, without medications that specifically address it. So very, very few veterans receiving that treatment. And if we look at medications for addiction treatment, which are approved for both alcohol and opioid use disorder, you can see in these two boxes, the box on the left, that only about 11%, and this is a very broad definition of alcohol use disorder that includes topiramate, which is not typically thought of as one of our core medications. So, very few folks actually getting medications for alcohol use disorder, about 20% of folks getting medications for opioid use disorder. So certainly a lot of room for improvement in terms of those numbers. Next slide. So I'll turn it over to Emily after this slide, but this project, CARE-VASH query, was born out of that data and born out of the idea that national implementation of these evidence-based practices could really advance VA's commitment to end veteran homelessness.
Thanks so much, Sonia. Really excited to be here with you guys today. I'm Emily Treichler, assistant professor at UCSD and with the DISC and at VA San Diego. So this all, of course, leads up to our two EBPs that we intend to implement at 12 HUD-VASH sites. And as Sonia was saying, there's a lot of evidence for both of these EBPs. I'm going to talk a little bit about a little bit more, but we know they're not that veterans are not getting sort of the access that we'd hope for at this point, and especially veterans in HUD-VASH. And so the goal is to increase access specifically in HUD-VASH and kind of reduce barriers that veterans may be experiencing in HUD-VASH. So that first EBP is medications for assisted for addiction treatment, specifically for alcohol and opioid use disorders, and to really implement that among HUD-VASH teams. And then the second is CBT for substance use disorders, which is more broad. It can be used for kind of across any substance use disorder, although there is some evidence that it's the most effective for stimulants. And to implement that within HUD-VASH case management and social work teams. Next slide. We know that MAT, medications for addiction treatment, are effective for alcohol and for opioids. And those have been a long-term priority for VA, but they haven't been implemented yet in HUD-VASH. We know that these are life-saving medications, and that in HUD-VASH and in kind of housing insecure folks in general, that this is really a priority area. So yes, so a key area for improvement. Next slide. And CBT said, CBT in general is a very effective therapeutic approach. CBT is specifically effective for substance use. It is a harm reduction approach, and so it can be helpful for folks whether or not they are achieving or attempting to achieve sobriety. It can reduce frequency and quantity of use, and also linked to other improved outcomes like social functioning and quality of life. And the other benefit for us in terms of CBT SUD and implementation science is that it's pretty tailorable. It's pretty flexible. It can be done individually and in groups. It can be done virtually or in person. It can be done in a veteran's home when we're thinking about HUD-VASH and the case managers are often visiting people at home. There are a lot of ways to do CBT SUD with fidelity. Next slide. So our goal here is to do a hybrid type 3 trial and to compare the impact of 2 implementation strategies to increase access to these 2 EVPs. The first implementation strategy is training and technical assistance. Our goal here really is to emulate the VA's existing implementation strategies and just expand and then tailor that to HUD-VASH. And then the additional strategy I'm going to talk about a little bit more is consumer engagement. So we know in VA that for MAT, academic detailing tends to be kind of the word of the day for MAT. And so our intention is to really expand access to that. And again, for HUD-VASH, and again, do some tailoring. And CBT SUD is one of many psychotherapies that VA has done what's called an EVP rollout. So doing a really intentional job of trying to train VA clinicians to a fidelity standard and provide certification. So really getting buy-in from VA clinicians. However, HUD-VASH does not have access to that EVP rollout. So our goal is to expand access to a kind of similar training and technical assistance model for CBT SUD while really tailoring it to the need of VASH, both in terms of the clinicians and their veterans. Next slide. We chose consumer engagement for our additional implementation strategy because we knew that the training and technical assistance strategy does not address some of the other potential gaps that could be a barrier for veterans who are considering engaging in EVPs. And that might include knowledge and motivation. And so we knew that we were mostly looking at training and technical assistance as a top-down strategy, how to better prepare and engage clinicians in those EVPs, but we also need to consider the other direction of veterans. And so our goal here is to work with peers and to both have peers engage veterans directly, but also to prepare materials that will kind of assist veterans in understanding their options better and be more engaged in EVPs, in both EVPs for the SUDs. Next slide. So our plan based on that is to do a cluster randomized trial. across these 12 sites in 3 cohorts. Some of the sites, half the sites, will get just training and technical assistance. The others will switch over to training and technical assistance halfway through, so that we'll be able to compare the benefits of the addition of consumer engagement across a number of metrics, including improvements for veterans, but also things like cost, and to make a business case for what might potentially be an improved access to care, but also what we expect to be an increased cost. And I think that's all our slides. So thank you.
Thank you so much, Sonia and Emily. I guess I didn't realize that you had this partnered evaluation, and that kind of informed your query development. So that was interesting for me, and I love the clarity of the study design as well. And now we are going to move on to the third query. And so again, please put your questions in the chat or hold them, but we will have a discussion in a moment. This is the iTRIP query that I'm going to invite James to start us off on, and then I will jump in at some point.
All right, well, thanks. Hello, everyone. I'm James Pittman. I am the Associate Chief of Staff for Mental Health here at VA San Diego, among other things, and happy to be able to present this work that we're doing. So our query is the Innovative Treatments for Recovery Implementation Program, and our focus really is in implementing innovative treatments for post-traumatic stress disorder and treatment-resistant depression, with the goal of specifically offering veterans at 2 different sort of ends of the spectrum of need, both like kind of a moderate to low need to a very extreme high need of mental health, to be able to try to improve a variety of different VA priorities. So suicide prevention, general outcomes, access to services, whole health, which is an initiative within the VA to try to improve not just reduce symptoms, but to improve the overall well-being of veterans, improve quality, value, and efficiency. And so we'll talk a little bit about the specific EBPs and how they fit into that impact goal in a few minutes. But as you may know, a lot of veterans access mental health services, and PTSD and depression are 2 of the most common disorders that we see in mental health. And then the subset of folks with depression with treatment-resistant depression is associated with really negative outcomes, a high comorbidity with PTSD, and not a lot of treatment options. And so when we say treatment-resistant depression, we're really talking about depression that is not actually getting better with traditional first-line approaches of medication and potentially psychotherapy. Next slide. And so our query is implementing 2 different evidence-based practices. So the first being mantra repetition. Mantra repetition is a meditation-based protocol that includes the repetition of a spiritual word, a concept called one-pointed attention, and then the concept of slowing down. It was developed here by colleagues at our VA Center of Excellence for Stress and Mental Health. So it was developed here, and it's had a couple of large randomized controlled trials showing the large effect in reduction of PTSD symptoms, but also overall improved spiritual well-being, reduced insomnia, and overall well-being. It can be delivered in a variety of different ways. So it can be delivered kind of in a group format, it could be delivered in an individual format. And then our colleagues here who are part of our query also developed a way to have it be self-directed, and so that patients or veterans can be able to learn how to use mantra repetition using modules that are available online. It can be done asynchronously. And so we'll be implementing that for low to moderate acuity PTSD at 12 different VA sites. And then the second EBP is ketamine therapy. And so ketamine therapy is a rapid-acting antidepressant. It's been FDA approved for treatment-resistant depression. And it rapidly reduces depressive symptoms and has been a high priority for VA and the Office of Mental Health. It also has significant implications for suicide prevention. And so our partners are Office of Mental Health, Suicide Prevention, and the Office of Suicide Prevention. And then ketamine has a variety of different ways that it can be administered. There's intranasal ketamine. There is IV ketamine and can be also done intramuscular. And so this is a much heavier lift in terms of implementation. And so we'll be implementing ketamine therapy in only 4 VA sites. Next slide. So we're using the practical, robust implementation and sustainability model, PRISM, to guide all phases of our query. So PRISM will be used where we're looking at the multi-level contextual domains, including intervention characteristics, organizational and veteran characteristics, implementation and sustainability infrastructure, external environment, and then the perspective of both of the veterans as well as the organization on the treatment. And so using PRISM, we will be doing a couple of different, we have a strategy bundle that will be our implementation strategy. We will use an iterative PRISM assessment that was developed by Borshika and colleagues, and which will be a structured periodic assessment of the contextual elements of PRISM and the fit with the evidence-based practice and the implementation at the specific site. And then it allows and then a review with the various stakeholders who complete this information from each of the sites to prioritize and create an action plan to address areas that may be lower scoring on the assessment. The other implementation strategy is a modified rapid process improvement workshop. Within the VA, rapid process improvement workshops are often used in systems redesign and quality improvement. And our team here at VA San Diego has used rapid process improvement workshops in a variety of different projects. We've made lots of modifications because traditionally rapid process improvement workshops were developed to look at a system and identify places where there could be waste and there could be efficiency gained. So we've modified them so that they're actually specifically focused on implementing a specific evidence-based practice. And then we'll do training, so ensuring that the sites where we're implementing have adequate training to be able to deliver mantra repetition and ketamine. And then blended facilitation, where we have both an internal champion and an external facilitator from our team working to implement during the implementation phase. Next slide. And so then our data collection is going to be a variety of different things. We've developed a PRISM survey, so we'll be assessing context and potentially the way that our implementation strategy makes changes in the contextual elements of PRISM. We'll be doing qualitative interviews. Dr. Hamilton is one of the investigators on this, and so we'll have the benefit of having her expertise in qualitative methodology. And then we'll be looking at a lot of VA administrative data. So the VA is the largest integrated healthcare system, I believe, in the world, and so we have a lot of data available to us, and so we'll be looking at a variety of metrics that are often categorized within the VA and used to basically tell how VAs are doing in terms of access, satisfaction, efficiencies, and a variety of other things. And so we'll be looking at those across the REAIM outcomes, so reach, adoption, effectiveness, and maintenance. We have an economist, a health economist, and we'll be doing an economic analysis, and we'll be doing adaptation tracking to be able to capture adaptations from both the actual evidence-based practice, how it's changed when it's implemented at different sites, but also the changes that we may make to the implementation itself. And then next slide, I think I'm turning it back over to you, Borshka.
Thank you so much, James. So as you heard, our overarching framework is the practical, robust implementation and sustainability model. And I'm just showing this visual because we always encourage, especially those of you who are in the training stage, that you make the framework yours. So here is an example where a slight adaptation of the framework really brings in the local setting, language, and how they are called within the VA. So we talk about veterans, families, and caregivers. We are talking about our EBPs in it. So you can change the look of your theory model or framework, whether it's EPIS, whether it's PRISM or CIFER, to reflect the type of groups and settings within which you are working. So that's certainly something that we have done with many of the activities for the query, but also the prior project that James was the PI for, which was a merit award that built to this query. And so you can see that our design is stepped wedge design, very similar to what I think Emily showed, that there is a cluster randomized design where we have different cohorts. So in the case of the ketamine therapy, we will have one site in each cohort because we have 4 of them. Over time, there are, of course, changes. We have a pre-implementation phase where we are preparing. So within each site, we will do a lot of work preparing them to be ready, collecting some data about the site that can be used to tailor some of the activities we will do. James mentioned to you the adaptation documentation and also how much flexibility both the EBP and the implementation strategies have. There will be a lot of modifying based on the site's preference of how they want to actually operationalize the implementation strategies. In preparation for that, we actually went through an exercise of distinguishing functions and forms for the EBPs and the implementation strategy bundle elements. And we will be working with each site to identify what the forms are, but we have a list of functions and subfunctions. So the adaptation documentation will really rely on that. And then you can see lots of data collection in the pre-implementation phase. All those colorful icons are indicating different types of data collection intents, include a combination of, again, qual and quant. But then as we move into the implementation phase, we continue collecting data, especially the interviews, and then the data bases that we have available to us will be sources, as well as continuing documentation of adaptations. The implementation strategies are also changing over time. So again, it's not one thing that you do throughout. Initially, we are focused on training and rapid process improvement workshops that James described. But as we get into implementation, we are moving more into the facilitation, both internal and external, and the iPRISM activities, the iterative PRISM activities. And then we have a substantial sustainment phase. We want to see what happens once we are not actively facilitating. And so we will be collecting more data after that. So that's our design, and that concludes the presentation by our 3 queries. I am going to just show you a summary table because I know that you have heard a lot of things. And while this is up, I'm just going to orient you to this and open it up for discussion. So please prepare your questions. You can see here the evidence-based programs that each query is implementing, the strategies that are proposed to be used, the key theories, models, and frameworks that we are using to guide our activities, what are the primary topics that we are focused on, and then the focus on which population primarily, and you can kind of see that. And I will emphasize again that we have plenty of opportunities actually to interact across these queries, even though they are focusing on different types of veterans and different types of problems. There is mentoring activities happening. There is a lot of methodological opportunities. You already heard that Alison is on our query for qual. I work closely with Emily on some activities. So there is a lot of opportunities for synergy. With that, I'm going to stop and we'll open it up for discussion to the group. Please bring forward your questions. I will also check the chat, but just unmute and come on. Any questions?
I have a question for Empower 2.0. When you say that the data, the various strategies, the 3 strategies were similar in their outcomes, does that include the qualitative data as well?
Great question.
From the interviews from the veterans.
Right. So in our previous Empower the 2 strategies, so this is our findings related to the strategies so far are based on data from the stages of implementation completion, or SIC. So we've been keeping that database of all the work that's happened with the strategies across the phases of the SIC. And so far, we're not seeing that one strategy, got sites to implementation completion more quickly than the other. So we're doing some more nuanced analyses with the SIC data at this point, but there's some signal that evidence-based quality improvement might be associated with stronger sustainment, but it's not highly significant, at least as far as we can tell yet. And then we're still working on our results from the cluster randomized trial. So that's going to be a whole other set of data analyses that are ongoing right now. Thanks for the question. Yeah.
Thank you.
How about others? And questions about generally how the query works or how the VA research works those are also very welcome. David, I saw you come on camera. I assume you have a question.
You just read my mind as far as just a better understanding of the query mechanism, and if people do have specific practices that they think might be, potentially of interest to the VA. How does that process even go as far as forming partnerships or getting information in front of the right people for consideration?
My real query friends, please answer this question.
I mean, I can get us started. So the mechanism is for these query programs that we've described today. There's a tiered approach to the mechanisms. So there are small, medium, and large programs, and funding to correspond with those levels, and expectations as well for number of sites, number of evidence-based practices, et cetera. So today you've heard about 2 tier 2 and 1 tier 3 program, with Empower as a tier 3. And in terms of, if you have practices that might be appropriate for mechanisms like this, I would say, connecting with the VA researchers who focus on those clinical conditions, and they will know, how, to what extent those practices might align with current VA priorities, as well as high priority health conditions among veterans. And of course, that changes over time for many different reasons, in terms of, national priorities, as well as conditions that we see as the population of veterans changes over time. For example, veterans are aging, so we're going to see many, many more older veterans as we continue. So issues related to aging and healthcare conditions among aging veterans are getting more and more attention. And really just partnering with VA investigators, also seeing where even some early stage investigators might have work that's been funded, for example, through career development awards that might dovetail nicely with interventions that have been developed outside of the VA, but maybe have strong potential to be adapted for VA and for the veteran population. I've seen that happen a few times. So I think there are a lot of roads in. It is a little tricky to get into the system if you're not currently in it. But there are so many people, so many of us have joint academic appointments and, try to navigate these various connections and bridges that we have, especially when there are practices that would be of benefit to the VA healthcare system.
And David, I don't know if you already have an IPA perhaps, and I am just not going to share anything new, but I am just getting hired because of this new role, because you have to be part of the employee pool to be able to be a MPI. But I have worked with the VA for the past 12 years now, I think 11 years on an IPA, having to take some breaks here and there, but
Sure.
very successfully being able to interact with queries. Was not an MPI, but was able to be the lead of implementation science or co-lead. And I have really enjoyed that approach. I don't know how easy it is to get those right now approved at this time, but that changes all the time and it's worth it.
Sure.
I have really loved that dual role. So just wanted to hear that perspective. James?
Yeah, I'll just add to what Allison was saying. So this particular mechanism comes out once every 5 years, and so it's a once every 5 years, and then it's not there anymore. And so they have however many centers that they can afford to fund each 5-year period. But there are a lot of other mechanisms that are available through Query, and so some of them were mentioned, partnered evaluations and things like that. And so there are other ways to get funding at different points during the year. So it's not the only type of mechanism that they have available. And the other thing that I'll say is that part of the way that this is intended to work, I think, is that when you're trying to find out what evidence-based practice you're going to be focused on, the idea is that we really closely partner with what we call our operations program offices, which are essentially located in Washington, D.C. And so there's an office of mental health, there's an office of rural health, there's office of suicide prevention, and many others as that have been mentioned here today. And so those program offices have sort of the responsibility of operationalizing like the priorities of the VA secretary. And so those folks are the ones who we really partner with, and we count on their letters of support and their input and their guidance to really like drive forward what we're trying to do. And so it's a little bit different than like having the researcher initiate and try to convince everybody that this is a good idea. It's really meant to be a collaborative process with the national level. Although sometimes we do have to convince them of what the good idea is.
That's very helpful. Thank you all.
Wonderful. And then Greg, you had a question in the chat about the learning hubs, and just wanted to say that and I will again, Alison, you have 2 active ones, so you might be in the best position, but I would say that we also submitted one recently, and it's just an exciting opportunity. And Greg, I think that you have some connection with one of the learning hubs, so I know that you know about it. Just a wonderful way of expanding people's knowledge about certain methods that are often implementation science related, but I will invite Alison to say more about that as well.
Yeah, I mean, the learning hubs mostly, not entirely, but the learning hubs mostly focus on training on particular implementation strategies. So like one of the ones that I lead is a training hub on evidence-based quality improvement. And so that hub provided the training for EBQI in the Empower initiative as well as other initiatives. And then the other one that I lead is on rapid qualitative methods. So not exactly a strategy. That's why I say not all of them are strategy focused per se, but are related to, techniques, strategies, approaches that we use in implementation science. For example, there's a facilitation strategy hub, many different hubs available. And I would say, to the best of my knowledge, and other folks on the session might know of some other examples, but I would say that in some cases, the query programs call upon the hubs to provide training either to the field or to folks on the team. For example, if a program is going to use facilitation, they might have their team members go through the facilitation training provided by that hub. But I wouldn't say they are inherently connected beyond all being query funded. But they are kind of in the same sphere of supporting the field. A lot of all of the query programs have mentoring cores. And so in many cases, the mentees that are in the mentoring course go through several of the relevant trainings that the hubs provide, for example. So I think there are good and interesting connections, but they aren't necessarily working inherently with one another, but others may have different perspectives on that.
I agree.
Thank you so much. Sonia, you were answering a question in the chat. Just wanted to see if you needed to add anything to that.
Oh, no, there was a really good question about could a veteran participate in multiple EBPs caused by different queries or a single EBP? Like we're working with veterans with substance abuse. Could they get CBT and medications for opioid use disorder? And I think that's in theory possible. I know, for example, the queries went through two cycles. Some folks were funded in the first cycle and some folks were funded in the second. And I know there was a specific emphasis for people resubmitting that these are the facilities that have already been touched by the funded queries, and we want you guys to go elsewhere. So there's really a goal to spread to sites that really don't have a lot of implementation science and research support. So while it's possible, it probably doesn't happen that often.
Wonderful. Well, we are at the top of the hour, and I realize that there might be more questions for us. So please take advantage of the email addresses that I think we all provided. If not, just look us up and email us. I will say, being the kind of the newest to the VA in some ways, that I have really enjoyed working with the VA and the VA colleagues. It's incredibly rewarding. The data that is available, the level of expertise in implementation science. So if you are thinking about it, please initiate conversation with us, even though it's not easy to get hired right now, but perhaps that will change. And we look forward to interacting with you in other venues, because we all are affiliated also academically. So we'll look forward to that. Thank you so much for being here. I was going to invite the presenters to stay on just for a moment. I wanted to take a quick photo for our records, and thank you for being here.
Thanks, everyone.
The request for
Thank you.
is completed. Thank you so much. Okay. Bye, Isaac. I just wanted to take a quick photo. Is that okay? And then I know that everyone has to go. James?
Yep. All right. We're gonna finish up a call real quick. All right, ready.
Okay, let me do the photo. I don't know these two. I might be throwing people out. I'm going to remove these two people. Lori, I am removing you. I am sorry. I'm just going to. Okay, super. Thank you so much for doing this. I really appreciate it. Perhaps we should think about doing this again for something else.
I was also thinking if you haven't shared this with Query, they would probably be interested to know about it.
Mhm.
Okay. Or send it. Thank you so much. Okay, a smile, and I am taking the photo now. Thank you so much. Good to see you all. Really appreciate your time. Forward to more
Take
work.
care.
Thank you for
Thank
having us.
Thank
Happy,
Bye,
you.
everyone.
happy recovery, Borsika.
so much. Thank you.
Bye.